Okay, everybody, we're back. So next up, we have Dr. Sarah Sydlowski. And so Dr. Sydlowski is the audiology director of the hearing implant program at the Cleveland Clinic, where her clinical and research interests focus on implantable hearing devices, optimization of practice efficiency while maintaining strong outcomes, and development of innovative clinical delivery models. And so she's actually not here in person today, so her talk is recorded, but she's going to talk about improving hearing assessments and aids. So yeah, we'll get started with her talk.
Hello, my name is Sarah Sydlowski. I'm the audiology director of the hearing implant program here at the Cleveland Clinic, and I've had the good fortune of being able to support many of our individuals with neurofibromatosis who are dealing with hearing loss and sometimes also tinnitus, which is a ringing in the ears. And today I'm happy to talk with you about how you can manage the hearing loss that very often comes along with NF2. In fact, it's oftentimes one of the first signs or symptoms that people experience, and it can be one of the early reasons that NF2 is diagnosed. Before we can talk about how to manage hearing, first we need to spend a little bit of time talking about what we mean when we talk about hearing. Many people use that term very casually, and it actually includes a couple of different things. The first is audibility. And another way to think about audibility is the volume of sound. So, how loud or soft a sound is, whether you have access to perceiving that sound. But then the second component of hearing has to do with clarity or how understandable that sound is. And over the course of your experience with NF2, you can experience very different things when it comes to hearing. Sometimes it will impact that audibility, the volume, but oftentimes, and probably more importantly, it can impact that clarity. So some people will describe that they feel like they can hear the sound reasonably well, but it may not make as much sense to them. Sometimes people will say that it sounds a little bit like a stereo that's between channels, or a speaker that doesn't quite send the sound through clearly. And that can change over time as well. As we see different changes in either audibility or clarity, we'll manage those a little bit differently. So understanding the difference is really important. Also, when you have a hearing assessment, when you see your audiologist, they will complete a hearing test. And a standard typical hearing test or audiogram addresses both of these components. So when they're looking at audibility, what we'll look for is having you listen for those tones or beeps and reply when you can just barely hear that sound. And we're looking for the level at which you can hear that sound about 50% of the time. We look at different pitches, different frequencies, and we'll commonly see a difference across different pitches from low pitches to high pitches. Oftentimes, the high pitches are impacted first. And then secondly, we'll ask you to listen to words and to repeat those words back. And that will give us an idea of the clarity. Now, it's not uncommon that when high pitches are affected, we'll also see some reduction in clarity just because high pitches are important for consonant sounds. They start and end words and give them their meaning. But if the clarity is still good, if we can just make those sounds a little bit louder, then speech will be clear. But sometimes, particularly when the hearing nerve is affected, over time, even if sounds are loud enough, the clarity still just isn't there. And that's not something that we can necessarily restore or restore fully, at least. So we'll talk a little bit now about the different devices that can help you to manage your hearing if it changes. Now, before we talk about the hearing loss that's specific to NF2, I want to talk just a minute about hearing loss in general. And I think this is really important because the hearing loss that is experienced from NF2 is different than the hearing loss that many other individuals who experience hearing loss have. It is a type of hearing loss that's called sensory neural. And so that means that it does occur in the inner ear, but it occurs in a different place than someone who loses their hearing or has some hearing loss related to age or to noise exposure or to medications or many of the other common reasons for hearing loss. So the way that we hear typically is that sound goes into the pinna or the outer ear, and it's funneled through the ear canal to the eardrum or tympanic membrane. That tympanic membrane vibrates and it moves the three ossicles of the middle ear. These are the tiniest bones in the body, the malleus, the incus, and the stapes. The stapes is the last bone, and it kind of vibrates in and out of the opening to the cochlea. And the cochlea is the snail-shaped organ in the inner ear. It's full of thousands and thousands of sensory cells called hair cells. There are about 18,000, and they're so microscopic that all 18,000 could fit on the head of a pin. Those hair cells are all connected to a structure called the hearing nerve. And that hearing nerve travels through the internal auditory canal up to the brainstem, and eventually there are connections to the hearing portion of the brain. In typical hearing loss or more common sensorineural hearing loss, most people experience a loss of those inner ear hair cells. They can be damaged either from very loud sounds or medications or just using our ears over time. And so when you wear hearing aids, it makes sounds louder and allows the remaining inner ear hair cells to respond and still stimulate the hearing nerve. The difference in NF2 is that if we look at this image here on the bottom, which is kind of a zoomed in picture of the cochlea, we can still see the nerves that connect. And when that tumor from NF2 develops on the eighth cranial nerve, which is the hearing and balance nerve, it can put some compression against the hearing portion of the nerve. So in many cases, the inner ear hair cells are completely functional. They're doing their job just as they should be, but the impact is actually on that bridge between the inner ear up to the level of the brainstem. When that bridge is compromised, that means that the good hearing signal can't travel along the bridge, or it doesn't travel as effectively or efficiently along that bridge. And so the quality of sound that makes it to the hearing part of the brain is not as good. And so that's why very often we see that understanding or clarity tends to be compromised because the signal isn't able to be sent as clearly. Because of this type of hearing loss, there are 3 different devices that can be considered most commonly for someone who's experiencing hearing loss from NF2. The first type of device is probably the most familiar, and that is a traditional hearing aid. In our diagram here, we're showing what's called an in-the-ear hearing aid, but there are also more commonly devices that go behind the ear and have just a little wire or a speaker that goes down into the canal. The way that a traditional hearing aid works is it takes the incoming sounds and it makes them louder for the pitches that you're having difficulty hearing. Now, I mentioned before that when you have more typical sensorineural hearing loss, having the sounds louder helps the remaining hair cells to respond and stimulate the nerve. Many times in the case of NF2, those hair cells are working the way that they should be, but the nerve isn't firing or sending the signal in a good, organized, coordinated fashion. Sometimes having a little bit more volume can help the nerve actually fire more effectively, to be more synchronized in how it's responding to the incoming sound. So even though the hair cells aren't affected, having a hearing aid can sometimes provide more clarity, certainly more volume. But one of the potential risks is that over time, as the tumor increases in size, as the compression on the nerve advances, sometimes even having volume won't provide enough clarity. One other benefit of a hearing aid is that it can help to suppress tinnitus. So if you're experiencing tinnitus, which is usually a ringing in the ear, it can sometimes also be a buzzing or a roaring or another sound. Having some sound from the hearing aid can kind of mask or cover up that signal that you don't want to hear, which can make it a little bit more comfortable. Now, For many people with NF2, there will come a point when a hearing aid isn't able to provide enough benefit, and we need to think about a different option. Oftentimes, this will come after a surgery or at the time of a surgery to resect the tumor, where we know that the nerve has some compromise that's happening. In some cases, you can opt to pursue a different type of hearing aid, which is known as a cross or a bicross. And the way that a cross or a bicross works is if you have one ear that's not responding well to an incoming sound, you can wear a device that looks like a hearing aid, but is really just a microphone that picks up the sound on that side and then wirelessly sends it to a hearing aid on the other side. If you don't have hearing loss in that ear, it just delivers the sound at a comfortable volume. And if you do have hearing loss, it can boost the volume just like a traditional hearing aid does. The reason this device can be helpful is that it allows you to have awareness of sound that's happening on the side where you have a very significant hearing loss. But one of the downsides is that everything will sound like it's coming from the side that still has good hearing, because that's the side that will be picking up and responding to all of the sounds. If your desire is to be able to stimulate the ear that has the hearing loss, another option is called a cochlear implant. And if we look at our diagram here, we can see that there is a receiver stimulator package that is implanted behind the ear, kind of over that bone that sits right behind your ear. And then there's a very thin wire that's threaded through the bone behind the ear. It comes through that middle ear space and into the cochlea. It essentially takes the place of the hair cells that I mentioned normally fill the cochlea, and it directly stimulates the hearing nerve. Now, as I mentioned before, we know that the hearing nerve isn't sending a good clear signal, but if the nerve is still intact, provided the bridge still reaches from the inner ear up to the brainstem, then sometimes providing direct electrical stimulation through a cochlear implant can provide better clarity. It can also help to suppress tinnitus that might be occurring, and it's a good option when your hearing has reached a point that a hearing aid just can't provide adequate clarity. There are some risks associated with any surgery that you would talk about with your surgeon, but from a hearing perspective, there's kind of variation in terms of outcomes. Some people are able to understand words with their cochlear implant, and they find that having hearing in two ears feels much more comfortable and natural. The cochlear implant does sound different than our natural hearing. Many people say that it sounds more robotic. Some people say it sounds like a cartoon, like Mickey Mouse or Donald Duck. And it does take a lot of practice to learn how to train the brain to really listen and understand with a cochlear implant. Depending on how much the hearing nerve has been impacted by the growth and even removal of the tumors, sometimes the benefit from a cochlear implant is simply having some sound awareness. It may be that you're able to tell that someone's speaking to you. It might help the hearing to feel more balanced from one side to the other, but it may not provide as much clarity as your typical hearing in the other ear might be able to provide. Another consideration is that when you have a cochlear implant, because there is a magnet that holds the outside component you see here against the internal component that we already talked about, there are some limitations to being able to have an MRI. It's possible with current technology to go through the MRI scanner, but there is a shadow that's cast that can make it hard for your physicians to be able to see if there's been progression of the tumor. So in some cases, the surgeon will opt to leave the magnet out. The cochlear implant can still be utilized by shaving an area of hair over the implant and then using some wig tape or a small external magnet to connect the sound processor, the outside part, to the internal device. Now, in some cases, even a cochlear implant won't provide the sound that's necessary, and that's typically in cases where the tumor has become so large or during the resection, the nerve itself was actually cut or severed, and then a cochlear implant is no longer an option because the bridge between the cochlea and the brainstem is no longer in place. In that case, there is a device called an auditory brainstem implant. It is only approved for use in cases of NF2 in individuals over the age of 12 in the United States. It is very nearly identical to a cochlear implant in all components, except instead of ending at the end of the wire with a small electrode array that goes into the cochlea, instead, this wire extends to a small paddle, and the electrode array is on that paddle, which is laid on the surface of the brainstem in the area where hearing is detected. The advantage here is that it bypasses that bridge and sends the signal directly to the brainstem. The potential disadvantage is that the brainstem isn't quite as well organized in terms of individual pitches as that cochlea is, so it's a little harder to know when it's in exactly the right spot and that those electrode contacts are aligned with exactly the areas of the brainstem that code for different pitches. Because of that, the outcomes for open set speech understanding, which means understanding speech without knowing the topic or the potential words that could be selected, is usually not as good. And so oftentimes the benefit from an auditory brainstem implant is sound awareness, knowing that someone's talking to you. If you know the topic or the words they could be saying, maybe being able to recognize those. This can oftentimes be a helpful supplement to lip reading or other mechanisms of communication. The risk here is that oftentimes some non-auditory stimulation is possible because there are a lot of nerves that enter the brainstem in this area. And so we have to be very careful when programming this device to make sure that we don't stimulate other areas of the body that can be uncomfortable or sometimes even dangerous. And so that's something that we're able to work around. The last piece that's really important in NF2 is auditory rehabilitation, doing a lot of listening practice. It's like working out for your ear and your hearing brain. And because the different types of hearing that you can have can be very different with these different devices, that practice can be really important for keeping your ear sensitive to this information and able to get the most benefit possible. Your team will talk with you about what to expect as far as expectations, how to do that practice, and why it's important for your particular situation. And that leads me to my very last point, which is it's so important when you're managing your hearing to build a really fantastic team. This involves your audiologist, your otologist, your neurosurgeon, and together, understanding the communication goals that you have. This may also include a speech language pathologist who can focus specifically on that communication capability. Our goal is always to provide the best possible hearing for today, while knowing that it's very likely that hearing in one or both ears will change in the future. So we always want to plan ahead and make sure that we've set you up for success for a lifetime. Thank you for your attention. I'll be happy to answer any questions a little bit later.